Welcome, everyone, to our Network for Healthy Populations seminar. Today, we are delighted to have the subject of health coaching. What is the evidence and impact on diabetes prevention and management, which will be presented by my colleague, Dr. Diana Sherifali. Before we start, I would like to just begin with a land acknowledgement. So we would like to acknowledge that the land on which the region of Peel operates is part of the treaty lands and territories of the Mississaugas of the Credit. For thousands of years, Indigenous peoples inhabited and cared for this land. In particular, we acknowledge the territory of the Anishinaabe, the Huron-Wendat, the Haudenosaunee, and the Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. We are grateful to have the opportunity to work and play on this land, and by doing so, give our respect to its first inhabitants. Just a reminder that we are all treaty people, and many of us have come here as settlers, immigrants, and newcomers in this generation or in generations past. So we would like to also acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, and pay tribute to the ancestors of African origin and descent. Welcome, everyone, and thank you for attending today's Network for Healthy Populations seminar. Before I introduce you to Diana, I'd like to quickly review some housekeeping items. So first of all, we would appreciate that our audience mute themselves during today's presentation. There will be an opportunity for questions at the end of the session, and we will be inviting questions both through the chat box and by using the raise hand function. If you have questions during the event that you would like Dr. Sherifali to address at the end of today's session, please enter them in the chat box and we'll do our best to address the questions. Lastly, please note that today's session is being recorded and we will make sure this recording is available on our network's website after today's talk. So now it gives me such great pleasure to introduce our speaker for today. Dr. Diana Sherifali is very well known to many of you and is a colleague and friend of mine. And she's also an associate professor in the School of Nursing at McMaster University and the inaugural Heather M. Arthur Population Health Research Institute Hamilton Health Sciences Chair in Interprofessional Health Research. Dr. Sherifali's research interests include the implementation and evaluation of strategies to support diabetes self-management at the patient, provider, and population level, including diabetes health coaching. Dr. Sherifali has been funded by the Canadian Institutes for Health Research, Heart and Stroke, and Diabetes Canada, and she has published over 100 peer-reviewed articles which have helped shape diabetes clinical practice and policy in Canada. So please join me in welcoming Dr. Sherifali, who's going to present to you today on health coaching, evidence and impact on diabetes prevention and treatment. Go ahead, Dr. Sherifali.
Well, thank you very much, Dr. Lipscomb, for that wonderful and warm introduction. It is my pleasure to present on something that I've been super passionate about for a number of years, and that is health coaching. Thank you for the land acknowledgement as well. So in terms of disclosure, I have nothing to disclose that's actual or potential conflicts in relation to this program. And the agenda for this afternoon's presentation is just a high-level overview of burden. And I'm going to address this beyond the stats of prevalence and incidence, and then go into definitions of health coaching, the evidence for health coaching, and then lay some groundwork for some future directions that I have been a part of, but also planting the seeds for many of you as you go on to explore the role of health coaching in your own work as well. So what is the burden? So when we talk about diabetes, we can frame this from the standpoint of diabetes as a chronic condition or non-communicable diseases. We know that NCDs or non-communicable diseases are certainly on the rise, and they're only increasing in well-established economic countries, but also growing increasingly in low to middle income countries as well. And it's a leading cause of mortality and morbidity globally. The interesting thing that many have written about and talked about is that approximately 80% of NCDs, such as diabetes, cardiovascular disease, some cancers, even some mental health issues, can be prevented, delayed, or managed through some supportive strategies, such as pharmacotherapy, education, physical activity, and nutritional counseling. These two typically get lumped as lifestyle, or sort of a colloquial term as lifestyle, but I'll come back to that. And then another strategy that unfortunately does not have as much teeth because it's geared to more of a systems or political societal level are environmental or societal policies. So even though we know we have some evidence when it comes to preventing, delaying, or treating non-communicable diseases, some of these prevention strategies have a low uptake. And I think, two sort of more recent publications have really hit this home beautifully for me. One was a commentary written by a colleague at the Population Health Research Institute, J.D. Schwam, talked a little bit about sort of the burdens and the barriers at these three particular levels. So at a patient level, it's very easy to blame individuals to say, well, you just need to get your lifestyle in order, watch what you're eating, move more. But we know that despite education, despite giving people information, there are barriers to accessing ideal care based on knowledge, beliefs, but also cost and efficiencies of some of these interventions. At a clinician level, there's also some barriers in terms of knowledge and attitude, and then limited time. We're time impoverished as clinicians, so it's very hard to fit in all of this additional counseling around diabetes prevention and management. And then at a health system level, we're often facing fragmented care, where sometimes just the overarching management and good management is seen as sort of lower on the priority list. And then subsequently, siloed care offers limited infrastructure to integrate some of these care approaches. So there's certainly a new call to action and a new approach is required. And I'll certainly give a shout out to a Perspectives in Practice that was published by Dr. Fazli in the Canadian Journal of Diabetes, I believe just in October, that was really a rally call and a beautiful call to action. So if you need to see a little bit more about what that new approach might look like, I would certainly suggest you go there. But then again, if we think a little bit more about what is it like for the individual living with diabetes, for me, it's really a couple of things. One is that diabetes doesn't travel alone. It tends to come with other comorbid conditions. And some of them, obviously, this is not an inclusive list, but hyperlipidemia, hypertension, coronary artery disease, and certainly more and more we're seeing levels of anxiety, distress, and mental health issues that could be associated with living with diabetes. And then additionally, we find that people living with diabetes are often sort of torn between prioritizing and juggling what is important at any given moment, any given day, any given time. And then in the greater context, they're having to align what it's like living with diabetes to fit their cultural, environmental, and perhaps even social context. So this becomes quite burdensome. So if we want to actually go through this exercise of what does someone living with diabetes or a typical patient experience, I think this slide probably really hits it home for me. If we think about a typical healthcare visit occurring every 3 months approximately, which is usually aligned with critical blood work that is often ordered, we find that patients often have a visit where they're asked about, their current medications. Are they eating healthy? Are they monitoring their glucose? Are they being active? They're asked about reducing the risks, paying out of pocket for additional services, devices, supplies. They're asked, are they coping and how are they problem solving? So this is sort of the shopping list of things that might or may be addressed at every visit. And then subsequently, they're left with this list of things to do in between visits. So they have a visit at 3 months, maybe another visit at 3 months, and it's all of this stuff in between that's waiting on that patient experience. And that stuff in between, the middle, for me, is really where 90% of the work is being done. And for me, that's the golden opportunity of where health coaching is situated, and that is supporting people in the middle. So health coaching has been defined in a variety of different ways, but this is sort of a synthesis of some of the more foundational literature. Health coaching is a health intervention that provides timely and relevant education. I've been a part of diabetes education programs, in fact, created education sessions where we would run people through groups, see them, once a week for 3 weeks, and then they're out the door and we don't see them again, hoping and praying that they remember all of their education and sick day management for when they need it. Health coaching is different. It's timely, it's relevant, or what I'd like to call just-in-time education, a little bit of education based on principles of adult learning, where you look to problem solve based on something. So you need education for that moment. It supports and promotes and fosters behavior change and monitoring. It supports the well-being of individuals, in other words, where they're at, and not assuming that all individuals are at the same point in their journey. And health coaching can be delivered in person, telephone, or using multiple forms of technology such as apps or text messaging, SMS, etc. To date, health coaching has been demonstrated and shown to increase self-awareness, increase self-efficacy, facilitates behavior change, increases quality of life or improves in quality of life, facilitates behavioral change specific to variables such as physical activity and dietary patterns and eating patterns. And it can also support chronic risk or disease risk-related indicators, whether it's for diabetes or some of the complications such as BMI, blood pressure, diabetes-specific variables such as fasting glucose or postprandial glucose, and then, of course, cardiovascular disease and risk factors. And so the evidence to date for health coaching, I really like this sort of review of reviews or umbrella reviews, depending on how you're defining it. This was done by Peter Hanlon and his colleagues, and they decided to take a look at, broadly speaking, self-management support, which health coaching is situated in that umbrella term, and looked at a systematic meta-review of multiple chronic conditions and what worked essentially when it came to health coaching. So this meta-review of 53 systematic reviews or 232 unique randomized controlled trials across a whole spectrum of conditions, heart failure, asthma, diabetes. And what they found was health coaching interventions in this massive review of reviews found that health coaching comprised education, monitoring feedback, and frequent action plans as a result of that feedback. Telehealth facilitated clinical review for harder clinical outcomes, adherence support, psychological support, and then, of course, lifestyle interventions. And that comes back to the point about nutrition and physical activity. Excuse me. So outcomes of, and their definitions that were sensitive to all of the particular the randomized controlled trials could fall into sort of these 4 buckets. One were markers of disease control or clinical control or population health. Second was healthcare utilization, cost of healthcare. Third was self-management processes or elements of patient-reported outcomes. And then, of course, quality of life, which was also a measure that can be used to capture patient-relevant outcomes, but also cost. And ultimately, at the end of the day, with this big review of reviews, what they found was more intensive, multifaceted interventions offered the best improvements when it came to markers of disease control, healthcare utilization, self-management processes, and quality of life. And specific to type 2 diabetes, telemonitoring and feedback, along with that just-in-time education and behavior modification, improved glycemic control, most notably for diabetes. Around the same time, my team and I embarked on doing a review that was a little bit more bespoke and tailored to diabetes. And specifically what we looked at were individuals who had access to a health coach for their diabetes, but the health coach was a healthcare provider. So we had that strict inclusion criteria. In our case, we were able to find 8 studies that met our inclusion criteria from various parts of the world. And in this meta-analysis, we found that up to 1 year of access to health coaching resulted in a 0.32% reduction in A1C. So if you give someone access to a health coach, the likelihood of seeing a reduction on average is about a 0.32% reduction. Similarly, a group of researchers down the road at York University did a very similar review. However, their definition of health coaching by Perbaglu and colleagues was a little bit more expansive. They included health coaches that were also non-regulated healthcare professionals. And so they had a larger pool of studies to pull from. And what I appreciated about their review was they looked at it in different lengths of time and sort of really looking at that kind of Goldilocks effect here. What's too short, too long, and just right. And so in panel A, you'll see their pooled estimate for reduction in A1C was a 0.32 for anything that was 3 months or less. And 3 months is notable, especially for diabetes management, as our primary outcome of interest in most cases is glycemic control measured by A1C. Panel B looked at anything between 4 to 6 months, and notably here, the change in A1C was a little bit more drastic at a 0.5% reduction, probably on par with some medications that people use for type 2 diabetes. Panel C looked at anything between 7 and 9 months. Again, a greater increase or greater change in A1C, but this was only based on 2 studies, so we have to take that carefully. And then panel D was anything beyond, I believe, around 10 months and longer. And again, this change in reduction in A1C was 0.24, heading in the right direction. But more than anything, this review gave us a good heads up in terms of length of health coaching access. And so my team and I embarked on doing a randomized control trial of just that. Could we offer health coaching to people who were living with type 2 diabetes and offer it in a community setting where we could randomize people to health coaching versus usual care? So we were fortunate to get funding, and we had a wonderful supportive community health center that took on this wonderful role. And so it was a community-based randomized control trial done at Lang's Community Health Center in Cambridge, Ontario. We had our goal of 340 participants living with type 2 diabetes. All that we asked was they had telephone access. So at this point in time, we weren't really interested in a lot of flashy technology. Again, this was pre-COVID, so we weren't quite sure what sort of the level of digital access and digital comfort looked like. So we thought everyone had access to a telephone of some sort. A1C had to be 7.5% or higher. And we offered individuals who were randomized to health coaching to receive health coaching for 1 year. However, what we did was we sort of tailored the intensity of how health coaching was delivered. And the biggest signal for this option was actually based on the diabetes prevention program. So rather than looking at intensive access to health coaching for 4 months, which is what the DPP program did, we just fine-tuned it to 6 months, just making it easy to collect that A1C. So it was analogous with when A1Cs were collected. So quick, short interactions once a week for the first 6 months, and then once a month for the final 6 months. This is what was advised. Whether patients ascribed or stayed to that regimen or that routine, it was really driven by patients. So they knew that a coach was available at this time frame and this intensity in the first 6 months. Afterwards, in the last 6 months, it weaned off a little bit, but they knew the coach was there for them. The primary outcome was A1C. Secondary outcomes that we also examined included quality of life, 2 forms. Generic, which was the EQ5D, the European, essentially 5-domain quality of life. And then we used the ADQUAL, which was the audit for diabetes specific quality of life. And then We also examined self-care behaviors and cost effectiveness. And in this slide, we see that on average, we had roughly equal distribution of females in both groups. On average, their age was about 56 and 59. Although it looks drastic, that was not statistically significant or different in both groups. We tried to include a broader range of diverse communities and participants. So you can see the distribution of some of those other demographic data. Interestingly enough, on average, these folks were living with diabetes for 9.3 to 10 years, and yet they still came forward and wanted coaching support, which I thought was really fascinating. And again, even though they had access to a community diabetes program, their A1Cs were 9.1 and 8.9 respectively. So there was definitely room for improvement. In terms of our primary outcomes, so the mean change from baseline to 12 months after having access to a health coach for 1 year resulted in a change of 1.8%. The education or usual care group also improved, which is what we typically see with usual care, just even in having access to a program, but also being part of a study. There's a little bit of volunteer bias, so both groups improved. However, the mean difference between the two groups was a 0.49% change. Even after recognizing that we had somewhat of a smaller sample size, we still sought to adjust based on some of the baseline variables like A1C level, age, gender, ethnicity, all of that. We still found that the adjusted mean difference was a 0.5% reduction, statistically significant and clinically important, because again, that's on par with some medications that people take for their diabetes. So we were quite happy with that result. More importantly, what was really striking to us was not only did their glucose improve, but their quality of life improved, which we thought was stunning. So the health coach saw an uptick in their quality of life score of 0.2. So it's sort of a unit shift on their ADQUAL, or their quality of life assessment. The education usual care group saw a reduction in their quality of life. And so again, the crude difference was statistically significant. Even after we adjusted for some of those baseline variables again, it still came back statistically significant, which was really, really powerful for us. So not only could we improve population or clinical outcomes, we could also improve patient-reported or really meaningful outcomes for patients, such as quality of life. This slide just takes us through some of the other secondary outcomes specific to sort of metabolic or clinical parameters. We saw that there were improvements across the board in terms of fasting plasma glucose, LDL, triglyceride to HDL ratio, BMI. All groups, I would say, improved. There was nothing really to sort of highlight any statistical significant difference, but we just thought it was noteworthy that at the end of the day, ancillary sort of findings with health coaching is certainly improving the other cardiometabolic parameters in the right direction. So we were happy with those findings. And then our other secondary outcomes included health behavior change. Interestingly enough, we used it was an audit of self-care behaviors. Unfortunately, we did not find anything statistically significant between both groups there. I think it's safe to say that our tool, the Summary of Diabetes Self-Care Activities, it was a simple tool. I don't think it was specific and sensitive enough to actually capture the nuances of the behaviors that were changing with respect to health coaching. So an example of the Summary of Diabetes Self-Care Activities, we're asking one diet question. There were some specific diet questions, glucose testing, a foot care question, and a smoking question. So in hindsight, I don't think that was the right tool to assess health behavior at that point in time. However, I'm happy to report that healthcare utilization, interestingly enough, we actually found that more people in the health coaching group actually went to specialized diabetes care more so than the hospital setting, which was conversely the opposite. So people who did not have health coaching referred more to the emergency department for care versus specialized diabetes care. On average, people that received health coaching had a mean number of encounters of about 12. But if you go back and think that people had access to health coaching once a month for 6 months, and then once a month for the last 6 months, approximately 30 interactions were available, but the mean number of interactions that were driven by patients when they need it was only 12. So we thought that was quite interesting. And then the mean time within each interaction was approximately 10 minutes. So short, quick interactions were key. A colleague, Dr. Daria O'Reilly, did a cost utility analysis, and she actually determined that the telephone-based diabetes health coaching was cost effective. And then ultimately, we were very pleased to see that despite the fine-tuning of medication adherence, glycemic control through health coaching, there were no adverse effects, specifically hypoglycemia, ER visits, or hospitalized admissions as a result. And so, like any good researcher, I wanted to understand why this was happening. What was the secret sauce in all of this, I suppose? And so graduate student Tharshi Sugamaran led this beautiful qualitative study, interpretive description, where she purposefully sampled using maximum variation strategies to try to include as many different perspectives in health coaching. So folks who had access to the health coach, who use the health coach a lot, not a lot, and then somewhat in between, sort of that Goldilocks effect. Interviewed individuals to really understand what was their experience like with having access to a health coach. And what she found was 4 overarching themes. Individuals enjoyed the fact that they had access to someone that could support them with their ongoing challenges and living life with diabetes. It's interesting when we think about these folks were living with diabetes on average 9 to 10 years. They still found it important to have someone there that they could speak to about those ongoing challenges. Second theme was the idea of non-judgmental support, which I think was super important because, you know, despite going through education, despite, you know, having access to medications, they just like that accountability piece and just checking in with someone regularly that was non-judgmental, there to support them and there to support them on their curious journey of what's working and what isn't working. And aligned with that sort of curious journey is that guided behavior change. So on a weekly basis, people may be experimenting with their food, with their physical activity, and then they could quickly check in with the coach for some of that guided behavior change. And then finally, an overarching theme was just being mindful and sort of joyful of revisiting what is life like living with diabetes. So it was living a good life with diabetes versus, you know, being stigmatized and shamed and burdened by living with diabetes. And so part of our journey in terms of running the trial was also coinciding with some deep thinking about how do we ensure the training, the competencies, the fidelity of what we're looking to do in trials with how can we plan on training, implementing, and scaling up health coaching, you know, if this is successful. And indeed, in early 2017, great colleagues at York University and Dr. Michael Coons and myself led a workshop where we had approximately 20 interprofessional academic clinicians, thought leaders in the space of health coaching, come up with this sort of informed pathway that could work for diabetes, obesity management, and in general, chronic disease management. And so this is, at the time, one of the first of its kind in that it's credentialed from the National Board of Health and Wellness coaching training program. And above all else, what I'm really proud of is that because health coaching is not a protected title, this gives us a good framework in terms of ensuring that people have the competencies, the skills, and the fidelity that if we are embarking on health coaching, people are approaching this with the right skills and mindset. And so just where we're at recently is, more and more, in particular, I'd say the last 10 years, there's just been an explosion in thought around health coaching, whether it's for disease prevention, diabetes management. We thought it might be a good opportunity to revisit our review and update the systematic review, but also update it in the standpoint of reflecting outcomes that are of value to a myriad of interested parties or stakeholders around the table. And so we were specific to use the quadruple aim. And the quadruple aim, just very briefly, looks at assessing value from various perspectives. So value or effectiveness could be the patient experience, population health outcomes, reducing cost, and then the care team or the primary care team, the diabetes care team, the well-being of that team. And so when we updated the literature, we found 9 randomized controlled trials that met our inclusion criteria. And then we essentially analyzed it against the framework just to see where the evidence landed. And so in most cases, population health outcomes were reported, specifically the A1C. After reviewing the literature, we found that there was a modest reduction in A1C of 0.2%, a little bit concerning. But what we found was that, again, there was a lot of heterogeneity in terms of who comprised health coaching, the training, and it really got down to what was that Goldilocks effect: too short, too long, not enough. And then, of course, who was the health coach and how were they trained? The other interesting findings were small but statistically significant benefits in systolic blood pressure, BMI, waist circumference changes, reductions in weight. And then, of course, what's super important to people with lived experience is depression, distress, and particularly immediately post-intervention. So they felt that there was improvement with good or moderate certainty of evidence there. We also, in sort of good understanding of, we have great evidence, how do we move this into implementation? And so here in this case, we looked at the REAIM implementation framework of moving evidence into action, into clinical action. And so the same review articles were then applied to the REAIM framework. And the REAIM framework, just very briefly, looks at 5 key sort of domains. One is reach. How do you reach a targeted population? The effectiveness, how do you know if the intervention of the program, the model is effective? Is it adopted? How is it adopted from the institution where you're delivering the intervention? And then how do you ensure it's delivered properly? That's implementation. And then maintenance, the M stands for how is it delivered over the long term? And so what we found here, again, same 9 trials met this inclusion criteria, but what was a little bit disheartening was of the 5 domains and possible 62 criteria that could report on health coaching, 12 were reported consistently by all of them, and then 21 criteria were consistently not reported. So if we think about the evidence and evolution of where we're going for health coaching, we know there's good evidence that it's working based on the quadruple aim framework. What we don't have is evidence for how to best implement it. So that's more to be determined and down the road. So there's a paucity of limited implementation and clinical practice implications, which is meaningful as we try to turn this evidence into what can we do. We're hearing of many community health centers embarking on this work, which is great, but there needs to be some thoughtful implementation and practice implications from that. There's limited interpretation and comparisons across studies, and then of course limited application of the intervention to diabetes and other chronic conditions. And this certainly loops back to kind of the original slide. If we think about diabetes as non-communicable diseases, these are all conditions that carry very similar risk factors, whether it's healthy eating or not access to healthy foods and healthy eating, limited physical activity, smoking, and inappropriate use of alcohol. And so where do we go next? So for me, where I've been thinking about health coaching is really trying to understand how to harness and fine tune the intervention. I think there's a lot of great enthusiasm, and rightly so, for an intervention that's really supporting people where they're at. So for me, it's about how do we harness the role? And that starts with the training, the education, but then also the delivery. Is it done in person? Is it done hybrid, in person, telephone, technology? COVID has obviously been a game changer for us. And I think there's a lot of interplay in terms of intensity and duration. The other thing to think about are outcome measures. So I always go by, what's most important and meaningful to individuals, and then aligning it with those behaviors or values, but also within the broader context, whether it's a hospital, primary care, interdisciplinary teams, and then how do we best implement that? So sometimes our evaluation measures are just that. How are we implementing it? And then the final piece for me in terms of future research is looking at the use of technology. So some of it can be quite flashy with machine learning and AI. We were successful in publishing one paper. Subsequently, we need more data, better data when it comes to health coaching. So we're still looking at amassing our data for that. But then also technology can be something as simple as Zoom, Microsoft Teams, WebEx Teams, and I've got more examples of that as well. Another future direction when we think of health coaching is health coaching by peers, by individuals in society that can certainly support. I've had the pleasure of working with the Emerging Leaders Program through the World Heart Federation, and that is assessing the role of peers in chronic disease management, diabetes as well, in low to middle income countries. And what's so fascinating is some of the most ingenious, innovative approaches are done in communities and societies where they have very little to work with, but sometimes they're the most elegant solutions. So there's great learning from low to middle income countries that could be applied, to various contexts here in Canada, Ontario, and a greater horseshoe area. I'm very proud of the work with the Healthy Cities implementation team led by Mary Jung, which is using a train the trainer model of peer coaches that's looking at diabetes prevention in YMCAs. And I'm sure you'll be hearing about that a lot more soon. And then near and dear to my heart is health coaching for particular populations. And I think there's one group of individuals that are leading the charge. That's Dr. Russ D'Souza, that's looking at gestational diabetes prevention in women, South Asian women at risk for diabetes. And the one and only Dr. Lorraine Lipscomb is leading a massive project across Ontario, looking at bridging from the 3rd to 4th trimester of preventing diabetes following postpartum pregnancy. So that's a wonderful collaboration where we've been able to work with community partners, women with lived experience, colleagues at York University to really craft and customize a program for diabetes prevention in women. Some additional directions for health coaching is to further add health coaching in terms of multimodal approaches. So something more integrated. And 3 examples of this are looking at technology-enabled collaborative care. This is a project with CAMH, led by Dr. Carly Whitmore, Peter Selby, and myself, looking at health coaching and access to virtual mental health. Another example is remission for type 2 diabetes. So if you have type 2 diabetes, less than say 3, 4, maybe even 5 years, can we actually make your diabetes go away through intensive pharmacotherapy, multimodal sort of approach, fine-tuning nutrition patterns, physical activity, and access to a health coach in the primary care setting. And then our final project is looking at health coaching using machine learning. Not that the machine or tech will ever replace the human interaction, but how can it augment and automate some of this for scale and spread? So in conclusion, for me personally, I'm a big fan of health coaching. For me, it's really about supporting people where they're at. And it's really driven by the individual for the individual. And in a nutshell, I find that, as people live with diabetes, manage their diabetes, most of this is on the shoulder of people living with diabetes. It's that 90% of care that's done outside of the healthcare system. And for me, that's the niche where health coaching really fits, helps with supporting of the tasks and the behaviors. I think the other thing that we're learning quite quickly is health coaching is very amenable, adaptable, and it is effective in a variety of different lenses, patient-reported outcomes, clinical outcomes, and more research is starting to explore the role of peers. Obviously, we have good evidence when it comes to healthcare providers as coaches, and starting to learn a little bit more about how technology can actually push and optimize health coaching for scale and spread. But to that end, more work needs to be done to further test, evaluate, and implement, and particularly as we move to adopting and adapting health coaching routinely in our healthcare setting. So with that, I just want to thank everyone for their attention, and maybe if it's okay, Dr. Lipscomb, I'll stop sharing screen then, if that's okay.
Wonderful. Oh, Diana, thank you so much for such a clear and wonderful and informative presentation. I'm glad we left some time for questions. There's already a couple of questions in the chat. Maybe why don't we start with those in the chat, and then I'll go to Calvin. Let me see. So the first one is a question from someone asking, is there a place for AI in health coaching for chronic disease prevention? I don't know if you have any comments on that.
Yeah. So that's a great question. And I think the way we're sort of conceptualizing this at this point is that if you can think of, like, we typically see this scenario where it's a pyramid. And if we can divide the pyramid in three, AI machine learning is essentially, can we be using technology to push out prompts? And we see this, text messages, even with social media, you get those nudges and prompts. So that's sometimes what we call like nudge, behavior nudging, etc. The middle of that pyramid might be more of the hybrid, where a nudge may lead you and offer an opportunity to input data, but then once you've input data, a human may come on and then interact with you. So it's a hybrid of the technology and the human coach. And then sort of the pinnacle might be reserved for people that are perhaps a little bit more complex. It may be more situational. There may be critical milestones that are going on, that is strictly a human health coach. And I think what's really fascinating is that's kind of where my colleagues and I are thinking of this, and it's certainly not insulated. Someone could travel across all of those depending on the goals, the needs, and then, the situation and context.
No, that's great. That's really interesting frontier. Another question from Walter in the chat. One question was around with your RCT, the question around baseline characteristics, adjusting for baseline characteristics, the need for that. And then the second was just clarifying what you meant by a 0.5% reduction in A1C. I believe you meant it was an absolute reduction, right?
Yes, correct. So great question. So even though the baseline characteristics were not statistically significantly different at baseline, we were advised by statisticians that we should still adjust for baseline clinical variables and demographic variables because of the smaller sample size.
And then for the A1C, so I think just to clarify, when you say a 0.5 reduction, it's actually like if the person started with 8.5%, they went down to a mean 8.0%.
Correct. A 0.5%. So if they were 7.5, they dropped to a 7.
Yeah, which is actually, just so for those of you who aren't clinicians know, that's a pretty significant change in A1C. Most medications will result in an A1C change of 0.3 to 0.5%.
Yeah. Insulin, of course, is a little bit more powerful. Obviously, you're looking at a 1, maybe even 2% reduction. But, if you can offer someone a pill that reduces A1C by 0.5%, or health coaching that's going to have all of these ancillary benefits, of which I'm not minimizing this at all, but quality of life, behavior, I mean, that's a game changer, I think, for a lot of people.
Yeah. and probably more cost effective in the long run than medications. Calvin, why don't you go ahead and ask your question?
Thank you, Diane. I think that was a really wonderful talk and really relevant for the activities in this network. My question, I have two questions that are kind of related. Do you think that this role is more suited for health professionals or for people without a health background? Because there is the training program. Theoretically, you could have people who are not professionals come in and do this. And then the second question really, is more about implementation. As you know, we have a really good network of diabetes education centers across Ontario with existing dietitians and nurses. And do you think that this idea can be implemented within that structure? What would that require? Like, is it more of like a reorienting of the approach, or would more people need to be involved, or how might that look?
Yeah, thank you, Kelvin, for those two great questions. I'll start with your first question was around training. And my apologies, I should have made this clear. In the diagram with respect to the training and implementation from York University, the first sort of health and wellness coaching can be anyone can join up for that particular certification as long as they have a general health background. So this could be, personal trainer from Good Life Fitness, could be someone with a Bachelor of Health Sciences, could be someone that perhaps was internationally trained and has recently come to Canada. So there's a lot of opportunities with respect to that health and wellness coaching. A lot of the great skills, motivational interviewing, patient-centered approaches is absolutely still relevant, particularly for diabetes prevention or even NCD prevention. The chronic disease management, what we have landed on, and again, we sort of the broader panel of 20 folks from that workshop, was that indeed had to be a regulated healthcare professional. So what that then means in terms of implementation, I think you're right on key here, Kelvin, is that we have a network of diabetes education programs, whether it's at community health centers, primary care, tertiary care across Ontario, across the spectrum, where we have many certified diabetes educators that are ready and willing to go, perhaps need a little bit of fine tuning in terms of skills and training. But it would be really interesting to see what this might look like if it was implemented broadly. What I can tell you is in the coaching trial, we had one coach that fluctuated their time based on recruitment, sort of the waves of recruitment. And at maximum, one coach, it was a 0.8 FTE, which translates into 4 days a week, was able to support those many people for 1 year. Obviously, waves, some people were coming on board, maybe needed more frequent or intense interactions. Other people were going to once a month. But at the end of the day, it looked different and it felt different. And I would probably say, if we can reimagine, again, sort of almost like that triangle pyramid, is there an opportunity to think about who might best benefit from health coaching? If you're newly diagnosed, do you have access to a health and wellness coach that could really work on some of the health behaviors? Recognizing that this isn't about blaming or shaming the individual, but is there an opportunity for some exploration, fine-tuning? The second thing then would be if people are hitting critical milestones, complications, aging, whatever it might be, is that an opportunity to work intensively, closely for a short period of time with a health coach? That might be another interesting take on it. That's, again, probably needs to be further and tested. Maybe, Lorraine, that's our next grant. But I look forward to, exploring and hearing what others think.
No, that's great, Diana. We have a couple of questions in the chat, and then I've got Jillian with her hand up. So I'm going to try and get through the questions in the chat first. So there's a question about, is there a plan to test health coaching with adults who do not yet have an NCD to help, optimize prevention of future chronic disease?
Yeah, sorry. And who was that question from?
That was from Shannon Carey.
Oh, Shannon. Thanks, Shannon. Sort of. I would answer that as stay tuned. One of the shout outs to the future research was the city's implementation grant looking at diabetes prevention in YMCAs. And that is a unique model built on small steps for big changes led by Dr. Mary Jung. So it's peer support in YMCA. So the peers go through some training, almost like a coaching light version, with some motivational interviewing, et cetera. So stay tuned for more on that.
Yeah, great. Thanks, Diana. I'm going to go next to Jillian, and then we'll go back to the chat. Jillian?
Great. So that was a fantastic talk. So I just had a question about what you think we should be doing to promote more or to gain more information on implementation and research. Like, so is it around reporting standards, or do you think we should be doing more implementation, hybrid implementation effectiveness trials, or just get rid of trials altogether once we know something's, and just really work on implementation? And this kind of comes from a conversation I had with Walter at Heart House at a launch a couple of weeks ago too, that getting away from trials, which also take a long time and effort, and sometimes aren't set up to answer some of those questions. So I just thought I'd throw that out there.
Yeah, that's a great question. In an ideal world, I think we're done with randomized control trials. I think we need to, from a sort of a randomized clinical, sort of classic randomized control trial, I think we have data. We have enough data and evidence to show that we can move the needle with respect to A1C. So if we take that as sort of the foundation to then build off of, we know it's collected. We know that everyone reads it and interprets it. And what I mean by everyone is everyone in the healthcare ecosystem. And additionally, people living with diabetes are also well aware. That's kind of their dashboard. Whether it's meaningful to them is a whole other story. That then leads to what else might we be collecting routinely in the diabetes ecosphere? So more patient-reported outcomes. EQ5D is a great quick tool. There's the visual analog scale, like a little thermometer. Every visit, they can be literally pointing to something. You can collect that data, and the EQ5D can be used for quality of life adjusted years analysis, cost effectiveness. I'm not an expert. That's maybe more on Walter's shoulders, but I think that the ecosystem is there. It's just a matter of finding all of the assets, understanding what the value proposition is, and then I think it's just a matter of going for it. And it may mean a couple of sites are demonstration sites to get us going. I would encourage people to really take the time and think carefully about how health coaches are delivered. Again, there's a lot of heterogeneity in how that term is being applied and how that's actually actualized and implemented. But to that end, I think, the systems are all and the stars are all aligning, that I think we're on the cusp of something very important and critical here.
Thanks, Diana. Okay, I'm gonna ask some of the questions in the chat. We only have about 4 minutes. I want to respect people's time, so maybe I'll kind of go through and see how much you can get to, Diana.
Sure.
The first question has to do with frequency of the touch points, and that's something that we grapple with too in our study, is like, how often is there you did touch on the duration being important. Yep. But how about frequency? Is there evidence to suggest that more frequent touch points are more appropriate, are better?
Yeah. So the short answer to that is that it depends. And the it depends is if we take the proposition that this is person-centered, if we build the scaffolding or the foundation of saying, hey, once a week you can touch base with me, I'm here for you. Or once a week I will touch base with you, whatever that, synchronous or asynchronous is, connection. But I think the key thing is it's driven by the participants. So even though in the trial we set out distinct markers or touch points, we found that people didn't use the coach as often as what we had thought would work. That's the secret sauce. If it's built and it exists and people use it when they need it, That's important. It's driven by the person. And obviously there's some guardrails around that because they still have an existing healthcare team. They can still see their primary care providers, but what we're there for is for diabetes self-management support. So I think it's the intensity and sort of frequency is really driven by the participant. It's just a matter of are we available to them?
Yeah, and I mean, it remains to be seen whether there's some role for some scheduling of touch points to help with accountability for those people who are just, have a bad habit of not focusing on themselves. And if someone else is kind of nudging them that there's an appointment coming up, but that's something that I think we're still trying to sort out. To what extent do we want to provide some of that, specific those that force feeding a little bit of the of the touch points. I realize we only have 2 minutes left. There were just a couple of questions here. One is around whether if there's a scale on evaluating the fidelity of behavior change techniques, and then the other one is just more of a really great comment that maybe you can read later about whether it would be great to have an app that people could answer a few specific questions to help navigate different resources that they need. But I wonder if you could quickly, in maybe 1 minute, comment on whether there's a way to evaluate the fidelity of behavior change techniques when we're evaluating the effectiveness of health coaching.
Yeah, so with respect to health coaching specifically, there's nothing out there that I'm aware of. But in terms of behavior change techniques, more broadly speaking, if you're going through some training, Dr. Michael Vallis at Dalhousie, I think he is a professor emeritus, but has worked on some of that. I believe it was published in the Canadian Journal of Diabetes. I forget the time frame, but you might want to look up Dr. Vallis's work there. In terms of an app, great idea, but what we found through various discussions with our patient partners is that, especially when it comes to behavior, nutrition, at the end of the day, that's very personal. So whether you use Noom, whether you use a Fitbit, whether you use a Garmin, I think at the end of the day, as long as we have a program, an app, or something as simple as WebEx Teams or Microsoft Teams, that it's going beyond the digital, like, do you have this device and is this device syncing? It's used to facilitate discussion, used to facilitate communication. To me, that's the secret sauce in all of this, is the communication and relationship with the health coach and the health coachee. So no app, I don't think it's needed. I think we just can work creatively and maybe capture data in other ways through the sort of proprietary technology facets, but who knows? I may be proven wrong.
Diana, thank you so much. It's clear from all the questions we got and all the participation that this was, a really thought-provoking and amazing and very useful and relevant talk. Thank you so much for spending time with us today to share your great work and your insights. And this has been really wonderful. So thank you everyone for joining. Please join me in again thanking Diana for a wonderful talk. Please ensure you complete today's evaluation. The link is in the chat, and we'll also send it to you directly after the session. We will be taking a pause in December from our sessions, and we will be resuming our seminars on January 15th, 2024 at noon. And we're pleased to announce, along the same theme, and you heard Dr. Mary Young from UBC, or Mary Jung from UBC, is going to be coming and speaking to us about her primary diabetes prevention program that through the Healthy Cities CIHR team grant that she received. And I know that Mississauga is going to be involved in that program. So we're really excited that Mary has agreed to come and speak to us on January 15th. So we hope you can join us. Thank you very much. And thank you, Diana. Thank you everyone for joining today and for all your participation. Bye-bye.